very much.
Thank you, Darren. So I'm going to present on the public health disaster, just moving away from the national disaster, and specifically on the pandemic influenza as a public health disaster, especially as it happened in India, and we'll try to connect it with a particular framework of social justice. Now the pandemic influenza, it's not the annual influenza epidemic. It's mainly occurs with the novel non-human influenza virus, which jumps the species from the animals to humans and cause the sustained transmission from human to human infection. When it spreads globally, then it causes a pandemic. It's specifically a serious contagious respiratory tract infection, that is the upper respiratory tract infection. So as I mentioned, it's not a seasonal influenza, and the term epidemic gains the momentum of pandemic when the white-skull epidemic out of a new strain of influenza A virus subtype causes mortality and morbidity. It's unusually extensive, severe, and causes rapid epidemics in waves. Now, historically, sorry, why it's not coming? Right, I don't know why it's not coming here. So mainly we have seen 4 kinds of influenza outbreaks that we can say about we can tell them that they were the pandemics. First of all, there was the Spanish influenza in 1918-1919, and the positive agent was AH1N1. I don't know why it's not. So, okay. And
Change the laptop.
the estimated mortality out of it was 20 to 50 million. The next major influenza outbreak, which was pandemic, was the Asian influenza of 56-58, which was caused by the agent AH2N2, and the estimated mortality of it was 1 to 4 million. Next, in 68 to 69, there was Hong Kong influenza, and the subtype was AH3N2, which caused the estimated mortality of 1 to 4 million. And as we know that recently in 2009-2010 there was another pandemic influenza, which is popularly known as swine flu. It was caused by AH1N1, and the estimated mortality was 100,000 to 400,000 globally. That's the next one. Yeah. So the consequences of pandemic influenza, as we see, it's a high consequence pathogen. It has got a high virus with it, causing tremendous life loss and severe illnesses among the population. It causes extensive economic loss, hinders the commerce and travel within the country and in between the countries, just obstructing the livelihood or hampering the livelihoods of the people. It can also cause large-scale socioeconomic disruption. It can cause trauma, fear, anxiety, stress. And by World Health Organization, it has been considered as a major public health threat. Now, WHO, even though there were a number of pandemics in the past, and most recently in 2009 and 2010, still WHO mentions that it's very unpredictable because of the nature of this causative agent or a virus, because it mutates a lot. So every year, almost it's mutating, and you never know when the next pandemic influenza would cause. Now, besides these consequences of pandemic influenza, what has also been noticed is that pandemic influenza outcomes are related to the health inequities. And there are several social determinants of health that causes this health inequities during the pandemic influenza. Now, the social determinants of health, as many of us know, it causes the health present in the society. The left-hand side picture, it demonstrates that. It causes the health present in the society. The people who are of the higher class are found to be in good health. The people who are of lower class or low socioeconomic background, they are found to have the very poor health or health outcomes. During the pandemic influenza outbreaks, similarly, the social determinants of health have been found to be very opportunistic to affect the people mainly of the low socioeconomic backgrounds and cause the unequal levels of illness and death. Considering all these consequences of pandemic influenza, WHO recommended that each and every country of the world should have a pandemic preparedness to manage the pandemic outbreaks in a just and fair manner. So basically the pandemic influenza plan is a national level preparedness and response plan. It is a phase-wise multi-sectoral document prepared by health authorities. Why it's a phase-wise? Because a pandemic influenza is divided into 5 or 6 phases. So it starts from when the A virus starts mutating and circulating and jump the species from the animals to humans, and then it circulates among the humans. So from starting from that, and if the phase 6 is when it causes the sustained human-to-human transmission among the population. This plan is a multi-sectoral document because it's not only the task of the health department, but different other socio-economic departments are also involved in preparing the plan. For example, as one of the consequences I mentioned, that it causes the large socio-economic disruption. So to prevent that also, there is a need of the roles and responsibilities from the other departments as well. Excuse me. So WHO from 1999 onwards, it recommended that the pandemic plan should consist of the 5 basic components. For example, there should be coordination, situation monitoring and assessment of the virus, reducing the spread of the disease, continuity of the healthcare provision in all the phases of the pandemic, and there should also be the communication, and there should a plan for the communication as well. Now, not just only those consequences, but when we look back to the other sort of pandemic sort of outbreaks in the world, then we see, especially during the SARS and avian flu, some ethical issues also arose during those outbreaks. For example, during the SARS outbreak, there were some unfair allocation of scarce medical resources, which caused injustice into the society, into those countries, especially in Taiwan, in China. Now, from Taiwan and other neighboring countries, it was reported that unprotected and untrained healthcare workers face maximum risk but received unfair treatment. From China especially, the enforced quarantine and isolation and the violation of rights and liberty were reported. For in one example, so for I remember, in one of the hotels, there were the travelers in China, it was just sealed with the red tape from outside, just to mark that some of the people within that hotel were infected with the SARS, and nobody should enter the building or should come out of the building. Now, during the avian flu of 2005, there were forced culling of the poultry, but no compensation were paid to those farmers where the forced culling were taken place. And even if, for example in India, even if they were paid, it's so meager that didn't compensate their loss actually. Because that was these farmers, mainly their livelihood is on the poultry farming. And time and again it has been reported that there were no or insufficient risk communication among the people affected, among the government officials as well, and also in between the government officials and the people affected. And nevertheless, there were disproportionate loss and suffering by certain groups mostly affected by the socio-economic determinants of health. So all of these events or issues then make the WHO to promote that there should be inclusion of ethical considerations to address these issues during the epidemic and the pandemic outbreaks. Now, before 2007, WHO didn't mention that ethics is to be there in the pandemic plans, but from the SARS onward, and maybe from SARS onward from 2003, then after in 2005 again influenza outbreak, WHO recommended in 2007 came up with the recommendation that ethics is to be there in the pandemic plan. So the 4 themes that WHO mentioned is that there should be the ethical consideration of access to therapeutic and prophylactic measures. There should be implementation of fair and just or proportional public health measures so that it's a fair distribution of benefits and burdens are seen in the society. There should be the professional roles and obligations of the healthcare workers, their employers, governments, and that of the country as well. And as it has been noticed during the SARS 2003 that China was not ready to disclose the information about this new pathogen. So WHO mentioned that there should be multilateral response between the countries to help each other with the novel information about the disease, about the pathogen. But unfortunately, this recommendation has not been followed by has not been evenly followed by the countries. The ethical consideration, for example, in one of my studies, so I considered how ethically the pandemic plans of India, Nepal, Sri Lanka and these countries are, how they are ethically prepared. So quite surprisingly, Nepal plan was more ethical than the India plan, and Sri Lanka plan was not that much ethical, but it was just far behind the India plan, and also that was in the draft stage. Pakistan was, that time Pakistan didn't come up with a plan at all, Bhutan as well, so they didn't come up with a plan at all. But some other Asian, South Asian countries, you can see that they have a proper phase-wise documented plan which were readily available and accessible to others, common people. But these countries, there's India, Nepal, Pakistan and Sri Lanka, every year they face with the avian flu epidemic, avian flu outbreak, and also of the annual influenza outbreak. So although there is not a proper ethical preparedness plans in these countries, but these regions face this influenza risk, and you never know when it can turn to a pandemic. Now, adding to those ethical recommendations, that Bellagio principles came up in 2006 and mentions that ethics is to be included in the pandemic plan with proper identification and enumeration of the traditionally disadvantaged people in the particular countries. It also recommends that there should be identification and enumeration of who are likely to be disproportionately affected by pandemic preparations, pandemic responses, and by the pandemic itself. It also says the inclusion of and to engage the disadvantaged groups and or their representatives in the planning process. And fourthly, it says to identify and address the special needs to prepare for and respond to a pandemic influenza in the country. But again, the study reveals that these recommendations are not fully addressed in the pandemic plans. Now, when it comes to the need of the disadvantaged population during the pandemic epidemic outbreaks, a group of researchers, they specify that there should be social justice in these disaster plans. For example, this came et al. In 2006. They emphasize that social justice is to be there in the pandemic outbreak preparedness planning, which will benefit from the benefit in assuring the protection of all individuals, but also and especially to those individuals who are in disadvantaged positions in the society in general and who gets worse during the pandemic outbreaks. But from then on, different social justice theories though have been followed, but again, it didn't follow, all the countries didn't follow it evenly. Now, my study was basically to focus on how the pandemic plan of India stands in respect to this background. Now, India's support from the Spanish flu of 1918-19 and 17 million people in India died out of this pandemic during that year. So once in one of the references that I got, it said that more people died in India during this epidemic than during 20 years of cholera or during the 4 years of World War I. And in the same description, it says that in Punjab, one of the northern province of India, the trains were packed with dead and dying passengers and streets and cemeteries were strewn with corpses. For the next pandemic of 57-58, there were 5178 reported cases and 1098 deaths. Now, Bengal, one of the eastern state of India, it suffered from the lowest mortality rate during the 1918 pandemic, but it faced the highest mortality in 1957 Asian flu pandemic. Then, in the last one, in 2009-2010 pandemic, the total number of reported deaths from India was 2762. But the highest case fatality were found in a particular group of 20 to 39 years, and the next highest was in under 5 years of age. Now, just going going through all the pandemics that have happened in India, at least the recorded one, what I found in my study is that there are the specific victims of excess mortality, which are the low-caste Hindus, some Indian Christians, but not the foreign Christians, some Mohammedans or the Muslims, some tribals and the females, and some geographical people from certain geographical areas as well. For example, during the swine flu, some rural people and in Rajasthan and who belong to the bottom quartile or indigenous population faced this disease much more than the other people. And there were certain socio-economic determinants of health, especially the malnourishment, dense population, lack of access to medical care, and gender, caste, class, religion, and lack of communication and some climatic condition which just accelerated this excess mortality among the certain populations and more than the other people of the country. Now, specifically, India has got two plans, one formed during the 2005 after the avian influenza outbreak, and one after the action plan which has been drafted after the 2009 swine flu or AH1N1 outbreak. Now, in the plans, the risk groups who have been identified mainly on the basis of their clinical vulnerability, but not on the other vulnerabilities which are found to be accelerated due to the socio-economic conditions. The strategy of both the plans have been to delay the spread, reduce the spread, but not to help the people to adjust or to cope with the situation. And the underlying vision of both the plans have been a concept of One Health, which considers that you can deal with the same strategy of animal health as you deal with the public health, but which is a very fallacious actually. And when you go to the review of the Indian pandemic plans, we found that both the plans, they have been formed according to the WHO guidelines, but at least apparently it seems so, they followed the WHO guidelines. So they have divided the plans in different phases, in different components, and mainly there is some strategic approach for the healthcare sector as well, and for the non-health sector as well, for the NGOs and others. But they didn't specify what the roles of the non-health sector would be. They didn't specify the exact responsibilities and roles of the non-health sector during the pandemic phase in the country. Now, when it comes to the Bellagio recommendations of inclusion of social justice in the plan, or identifying and enumerating who are the disadvantaged people, what their needs might be during the pandemic, we found that this is the situation of the plans. For the identification and enumeration for the plan 2005, there were only the identification as the poultry farmers, but no other socio-economic groups were identified. For the plan 2009, there were only healthcare workers and persons with comorbidities and essential service providers were identified as vulnerable to the pandemic. For the planning process, for the engagement and inclusion of these people in the planning process, there was no mention of it in any of the plans. And addressing the special needs of the disadvantaged, in plan 2005, there was mention of the colors, the animal workers and poultry farmers, but in plan 2009 there was no mention of any addressing the special needs of any of the disadvantaged groups. Now, when coming to the planning initiatives and the concern for equitable protection, we found that the committees, plans and decision-making bodies have been really hesitant, and there was no evidence of participatory planning process and decision-making in any of the plans. The surveillance network have always been insufficient, inadequate and remain questionable even after the annual influenza outbreaks in the country. The surveillance has been more on the serological and virological nature of the virus than the epidemiological features of virus distribution, which is really problematic for the populous country like India. The diagnostic laboratory and research network, which can ease the access and availability of the therapeutic and the prophylactic measures in the country, were relatively scarce. And after 2009, influenza research network comprises of only 12 laboratories for a very large and populous country of India. And involvement and service of private laboratories have always been limited. When it comes to the communication, we have found there is a dearth of communication between medical personnel and government, masses and public health authorities as well. But after 2009, some websites were dedicated for the particular event of the influenza, and there were participation of the print and visual media, but that also was very limited. But there was no concern for those who have access barriers, for example, access barriers to the information and communication, people who are living in the rural areas. There were no concern for them. When it comes to the vaccination, excuse me, we found that there is no evidence of separate prioritization plan. It's neither mentioned in the pandemic plan, neither there is any separate plan in the Ministry of Health and Family Welfare website. There is no evidence of this influenza vaccination in the National Immunization Policy of India. And the manufacturing capacity of the influenza vaccine, which the country started to manufacture after the 2009, was very low and mainly initiated after 2009, as I mentioned. The healthcare facilities, as have always been, it has been weak public healthcare system in general, and it was not ready to handle the full-fledged pandemic. And we have also found that the lack of critical care resources, for example, ICU and ventilators in all over the country. And those hospitals which have got these, they are located in the cities mainly, in the metro cities and the urban cities mainly. So what needs to be done we have faced, the country as a whole have faced number of influenza outbreaks, is already facing the annual influenza outbreaks, but there is no awareness and anticipation of the ethical issues, although during 2005 and 2009 the country has faced some. So there is a need of the awareness and anticipation of ethical issues in the planning process and the plan as a document as well, and also in the implementation procedures. Now, what I found that the ethical incorporation is to be mainly in the decision planning, in the management, and particularly in the planning components of risk assessment, surveillance, and prioritization to address the needs of the disadvantaged people. But I also feel there should be the consideration of social justice for the consideration of equitable protection through the plan. So the strategy should not just be the stamping out or stopping or delaying the spread of the disease, but it should also be the enabling and ensuring the people, the individuals and groups to cope with the phases of the pandemic so that they can also recover after the phase 6 of the pandemic. And finally, what is to be done is that not just the pandemic preparedness plan, also it is for the pandemic preparation and to prevention of that pandemic influenza, but the vision of the plan should not be just only the prevention of that pandemic influenza, but there should be a concept of health underlying those vision. Maybe the health can be conceived as a right, so that means not just the prevention of disease, but also it should mean as the capability and ability to achieve certain functioning. Say in this case, it should be the prevention from the escapable influenza, and there should be a concept of freedom underlying that concept of health to achieve such good health without the negative influence of the socio-economic determinants of health. And one other thing what I didn't mention, but I got influenced by Chang to mention that there should be a concept of shared health governance. It's not like that the individual responsibility to combat the disease, it's not just the sole responsibility of the state as well to prevent the disease, but somewhere both the groups, the individuals as well as the government, public health authorities, they should come together to collaborate and to govern the disease prevention well. So there should be a shared health governance in the pandemic prevention. And that's it. Thank you.
Thank you, Chama. Thank you, Rhyddhi, sorry. Chama, you stayed. Chama, do you have any comments before you leave?
No, lovely. I'm going to get back to you later on.
She agrees.
It's nice.
Okay. Any comments? Questions? So have you actually lived yourself in the presence of an epidemic or pandemic scare?
Yeah, in 2009 and 10. This year before I started my PhD, so this was a part of my PhD study at school. So I cut it and just to make it presentable here. Yeah, I was that time, just to mention one example, Bombay in Maharashtra state, it was the swine flu, the AH1N1, it was a very bad outbreak there. And at that time, it coincided with the organization of the event of the Indian Philosophical Congress. And Professor Amartya Singh was one of the main speakers in that Congress. And I didn't attend it, although I had the desire to see him, to talk to him there, in the Congress, but because of this outbreak, I had to cancel that idea.
Because your family was afraid, or you were afraid to get infected?
Yeah, family, friends, everybody then better not to go there. You can just attend some other sessions, but not this one because it's very bad there. And we couldn't trust the arrangement of that Congress as well, so we're scared that it might spread.
Yes, I was in Beijing for a few days before and after the declaration of the true numbers of SARS.
Mm-hmm.
So, because I was giving lectures on bioethics in major hospitals, and among the students in discussion, they said, "We have more patients with SARS in our hospital than declared for the country." And they were not declaring. But by the end of my visit, in fact, the government had decided to open up. But in fact, fortunately, I was not enclosed in any hospital. But at that time, when I went back to Japan, there was a general recommendation that people who travelled to an infected area should not come to the university for 10 days or so. But my return was just before that, and I felt I had taken reasonable precautions not to be infectious or to infect. But today I have an infection, but it's not from that, I think. We hope. It's okay, maybe it's just something which has been released since a recent presidential change, maybe to get rid of people like myself. Maybe. Bring it over to you. Any other comments? Swine flu has been a very big issue, yeah?
Yeah.
And there's also a big issue of corporate profiteering on the preparations for Tamiflu and other issues. That was a very big scandal. I think WHO was complicit in that as well, but maybe people didn't know, or the issue is if there's something which can only improve your recovery time by half a day or a day, is it really worth the government spending a lot of money? Or is it going to be valued because you can save a few individual lives who are very vulnerable people from death?
Yeah.
So how do you calculate? Because maybe for a few vulnerable people, they will be the ones who actually succumb to the infection. So in terms of the number of lives saved, it's not many, but it's still, should we spend money to prepare?
Yeah.
Expensive drugs to prepare?
Yeah, and the major thing in this drug thing is that in India during 2009-10 pandemic, it has to buy the drugs from the other countries, and the drugs first and foremost were distributed to the doctors and physicians who are dealing with the patients of this infection. So, but by that time, the people who are deprived already in the society and has got these infections, probably they have gone to the deathbed by that time. So that all of these issues that created a huge problem in the country from 2009. And now when I travel to the airports, although India has not been affected by Zika, but I see prominently there are advertisements to make the people aware of the Zikas and these kinds of infection. So probably there is a little bit of awareness in the country after the 2009 and 10, and mainly from the voices of the researchers in the country, but it's gaining momentum very slowly, but it's gaining momentum.
Thank you. There is a comment also, is there any update, this is from Leo, in the Philippines, any update since 2009 to the Bellagio plan?
Not really, because I've checked it till last year, so not really.
Okay. Okay. Well, thank you very much, Rhyddhi.
Thank you.
Thank you.